Our next presenter, I am personally indebted to. I'm personally indebted to Dr. Sborov for the exceptional and personalized care that he provides to my husband. And when Richard goes for visits, they will often talk about their shared love for skiing and for cycling. But until today, and on seeing his badge, I had no idea that he enjoyed handiwork. So I learned something new about him today. Honestly, I should have provided him with a pair of running shoes, though, because he has been running. He started his day with rounds this morning and has been running and rushing to get here to join us, and I'm so grateful for that. And he likely wears running shoes every day with what he's involved in as the director of multiple myeloma, the multiple myeloma program and division of hematology at Huntsman Cancer Institute. He is also a member of Huntsman's experimental therapeutics program. He's the physician leader of the multiple myeloma bone marrow transplant arm of Huntsman Clinical Trials Office. He's the leader of the multiple, let's see, I lost my track. He's the physician leader of the multiple myeloma bone marrow transplant arm of Clinical Trials Office at Huntsman Protocol Review and Monitoring Committee. I probably botched that up. And recently elected as a Huntsman Translational Scholar. His primary research concentration is the development of novel therapeutics for patients with myeloma. Along with this, he's working to develop novel anti-cancer agents and regimens. He's really working closely with the entire myeloma community to further develop state-of-the-art clinical trial and research program at Huntsman that offers patients the opportunity to take part in advancing cutting-edge, high-quality, next-generation treatment options. And I am personally so grateful for the work that he's doing there and excited for you to get to learn from him today. Dr. Sborov.
Thanks. Can you guys hear me? I got to shorten up that introduction. Thanks for having me. Welcome, my esteemed colleagues. That was a great talk on nutrition. I missed the exercise talk this morning, but I watched The Game Changers and I watched Forks Over Knives and changed my life, and so we've changed how we're thinking about this at the Huntsman. So so if you want to give us a pamphlet, the Nutrivention 2, give us a pamphlet and we'll get our patients on because it's awesome. Trying to do some of the same things for our patients at the Huntsman. I think that we need to start thinking outside the box of just treatments and just really start thinking about a more holistic approach to our patient care. So with that, I wanted to let you guys know that we're actually expanding our program. So the little slice of heaven that you see out here, it's only 20 minutes from the hospital. So anyway. All right, so let me see if I can figure all this out. I have been rushing around this morning, so I didn't have a chance to go through these slides on your presentation. So you guys are all savvy. You've read everything on Health Tree. You've seen all these different new drugs that we have, but I'm just going to provide you an overview, sort of how I think about it, how I present it to our patients. I think it's important you guys really grasp what's happening because right now we have a generational shift in the treatment of multiple myeloma. What happened 5 years ago is the ice ages. What we have now and what's coming forward is transforming. So my disclosures. So I was looking back at a slide that I presented at one of our coaches summits. I think it was 2 or 3 years ago. I don't know, everything becomes pretty blurry with the pandemic, but I showed a slide just like this, and at that time we didn't have Abecma, Carvykti, selinexor, we didn't have Blenrep, certainly didn't have teclistamab, and I was telling the story of my family, and so I'm the sixth physician, third generation physician in my family, and this is a picture of my dad a long time ago. And when I was going through my fellowship, he asked me, what I was thinking about doing. He wanted me to join his group as an oncologist in Minneapolis. And I said, I found this thing. It's called multiple myeloma. I think it's pretty cool. So his comment to me was, as you can see up here, what an awful disease. My patients don't make it. I need more tools. And so that was pretty motivating for me. At that time, there's melphalan, there's prednisone, some transplants, and maybe some more steroids, but we just didn't have a lot of tools. And so the second picture there is his retirement. And I say, happy retirement, Pop, don't worry, I got this. And so then we start moving towards our novel therapeutics, the proteasome inhibitors, the IMiDs start coming, and I'm at Ohio State doing my fellowship with Craig Hoffmeister, who's now down at Emory. I'm saying, this is great. We have 2 IMiDs, we have 2 PIs, and a drug called isatuximab. It's like Kool-Aid. Everybody's getting excited, right? Things are changing. And then all of a sudden, we've got more developments, we've got some monoclonal antibodies, and here's a picture of me, I think it was last fall, and I say, we aren't there yet, but we're getting closer. And so we've got this explosion, right? CAR-Ts, bispecifics, ADCs, they're all coming. And so this is a picture of my niece. She'll be the next generation. She wants to be a physician. And so I say, or she said to me, I'm going into surgery, nice job finding that cure, right? Because that's our goal, and we're getting closer. So, a list of FDA approvals since 2015. It's a limited list, but it's expanding. We got Carvykti this year. Some of us know Carvykti very well. We have a lot of drugs coming. We've got daratumumab that's been here. We have elotuzumab. We have selinexor. We have belantamab mafodotin, also known as Blenrep or Belamaf, our antibody-drug conjugate. Isatuximab has made its way into the scene. We have Abecma, our first CAR-T, or ide-cel, our first CAR-T in myeloma. Some more daratumumab, subcutaneous formulation, Carvykti, and we have teclistamab on its way, hopefully, in about a month. So this is our ever-expanding myeloma toolbox. I've had this slide in my decks for a decade. It's like one of my favorites, bless you. It just goes to show all the different tools that we have, and this thing gets bigger and bigger every year. So we've got the chemotherapy, we have steroids, the proteasome inhibitors, including Velcade, carfilzomib, and ixazomib, immunomodulatory drugs, including thalidomide, lenalidomide, pomalidomide. We'll have our cell mods coming soon. We have 3 different antibodies, elotuzumab, and the 2 anti-CD38 antibodies, daratumumab and isatuximab. We have selinexor, which is a selective inhibitor of nuclear export, an oral drug. We have our 2 CAR-Ts, and we have our antibody-drug conjugate. And then in gray, you can see those drugs that we're expecting to come on the scene, at least towards FDA approval in the very near future, bispecifics, venetoclax, and iberdomide. So, as we all know, we're getting better, but myeloma remains incurable. I can't wait to be able to update this slide, right? All old data, pre-CAR-T, pre some of the monoclonal antibodies. Overall survival, median overall survival, so still a little over 5 years, but we're getting better. You can see that. From the initiation, or when we started getting the novel therapeutics, we started getting better, and we're going to start making jumps here. And so when we go back and look at this data, the newer data, we can see that the median overall survival for those patients with standard risk disease is 10 plus years at this point. So we are getting better. But we're not there. So what are our goals of treatment? Well, I think the goals of treatment aren't going to change. We protect the patient, we prolong life, and we positively impact well-being. And this is how we get there currently. So you can see in the top here, I don't know if I have do I have a pointer on this? I don't think I do. So we diagnose our patients, we risk stratify them. Risk stratification is evolving at this time. We ask ourselves, is our patient eligible for transplant, or are they transplant ineligible? If they're transplant eligible, we start them on induction therapy. We consolidate generally with an autologous transplant, and then we put them on maintenance. And then at the time of disease progression, we give them rescue. In those patients that are not transplant eligible, we give them induction therapy, and currently we're treating until the time of progression or intolerability. And you can see on the bottom that this is our goal: disease control and reversal of symptoms. If we're killing those myeloma cells can't injure the kidney. If we're killing those myeloma cells can't cause fractures. So get disease control, get the patient safe, and then we maximize disease control to provide durable disease control while optimizing quality of life. I was talking to a patient the other day, and he's inpatient to kidney failure, fractures all over the place. I said, at the beginning here, we need to get your disease under control. Once we do that, then we can start optimizing your quality of life, and we'll find that right balance for you. So, how are we going to get to the next step? I stole this figure from Dan Sherbino, who's a myeloma specialist at the University of Colorado, because I just liked it so much. He took a lot of time putting it together. You can see that we get disease control for a while, okay? Median progression-free survival is longest in that first line of therapy. Then the relapses start. And the progression-free survivals decrease over time. And as you move towards the right, fifth, sixth relapse, in this case the patient was in 2019, you're talking about very little response to our drugs. I want that to go away. I know that my colleagues want that to go away, and that's what we're working towards. So what do we have? We have all of our small molecule therapeutics. I talked about many of these. Many of these are not in prime time. Our HDAC inhibitor, panobinostat, has gone away, but we do have the new generations of the immunomodulatory drugs coming. We also have the BCL2 and MCL1 inhibitors coming. Venetoclax is probably the one that people have heard the most about. But then you have selinexor, which is a very important drug, in my opinion, there on the bottom. And we'll go through that in a little bit. But this is why I'm here today. I'm just going to talk about some of these new drugs. So the antibody-drug conjugates, namely the anti-BCMA antibody-drug conjugate Blenrep. We have the bispecifics. We'll go through a number of those, including teclistamab, because you guys are going to be seeing a lot of news about that in the next couple of months, and then our CAR-Ts. We have three main targets right now. BCMA is our primary target for all of these drugs, so B-cell maturation antigen. It's important for B-cell development. Cell is supposed to have two L's, my apologies. Cell survival and proliferation. Two other targets that you should be aware of are GPRC5D, which is an orphan receptor, highly expressed on myeloma cells, and FcRH5, which is also expressed on mature B cells, and the function of this is unknown. What are these things? These are proteins that sit on the outside of the myeloma cell that we direct our drugs to, okay? So let's start with antibody-drug conjugates. All right, this is a picture of what Blenrep looks like, okay? So it's also known as belantamab mafodotin. It's a humanized IgG1 anti-BCMA antibody, and it has, basically what it has is connected to the arms of the antibody are some chemotherapy pellets, okay? What this drug does is it binds to the myeloma cell. It's internalized. When it's internalized, it drops off the chemotherapy pellets. Those chemotherapy pellets go into the nucleus of the cell and kill the cell. This is an off-the-shelf, outpatient, steroid-sparing BCMA-directed approach. Now, I've got a couple. I'm going to see if these work. Craig Cole, who some of you may know, is in Michigan. He treats myeloma, and he is way better at PowerPoints than I am. So this is what the ADC looks like. You can see that you have the antibody, and then you have the chemotherapy agent. They're linked together. All right, that's your myeloma cell. The drug comes down. I mean, isn't that impressive? I saw that. I was like, how does he do that? So the drug combines with or attaches to the myeloma cell. It's internalized. Those chemotherapy pellets drop off, go into the nucleus of the cell, and pow. Right? I mean, I'm going to tell him that you cheered for that, because I was cheering for it when I saw it too. Anyway, so Blenrep was FDA approved based on the DREAM2 trial, and this is a trial schematic. So patients had to have at least 3 prior lines of therapy. They had to be what we call triple-class refractory. What that includes is patients who are no longer responding to proteasome inhibitors, immunomodulatory drugs, or monoclonal antibodies. All right, so it included 200 patients. It looked at two different drug doses, 2.5 milligrams per kilogram every 3 weeks or 3.4 milligrams per kilogram every 3 weeks. We took from this trial that the responses were pretty similar between the two different arms, and 2.5 was a little bit better tolerated. And so we moved 2.5 forward, but now we're playing with those drugs, or that drug dose, and so I'll go through that, I think, in this afternoon's talk. Anyway, the overall response was 31%. For those of you guys who don't know what overall response is, to have an overall response, you have to have at least a 50% reduction in the amount of tumor, okay? Very good partial response is at least 90% reduction in the amount of tumor. So about 20% of patients had relatively deep responses, and this is what we're seeing clinically. So if patients respond, they can get deep, which is nice. Median duration of response was about 11 months. Median progression-free survival was short, and median overall survival was about 14 months. A couple points to make. Let's see. Made the first point. Patients with high-risk FISH or renal impairment had similar responses to the overall population. It's important because we're talking about late-line patients or in the late-line setting. They pick up mutations and the disease gets to be more aggressive, okay? And so to see that this drug can behave well for some people with high-risk cytogenetics is very important. Those with extramedullary disease did not do so well, and we're seeing that in the clinic as well. And I think an important point to make, and I'll get into the ocular toxicities here in a second, but we have to do a lot of dose holds with this drug. But what's very interesting is that those patients that did have responses were able to maintain those responses even when we held the drug. So based on the DREAM2 trial, Blenrep was FDA approved for patients who have had 4 prior therapies, including a proteasome inhibitor, immunomodulatory drug, and anti-CD38 monoclonal antibody. Now, what's really important to appreciate is that this is at least 4 prior therapies, not prior lines of therapy. So when we start talking about the approvals for the CAR-Ts, we're talking about lines of therapy. And if you want to better understand the differences between that, we can talk about it later. So Blenrep causes ocular toxicity. This is one of the reasons why the drug's getting a bad name. So what happens is that there's probably some off-target effects on the corneal epithelium, so the outside layer of the cornea. What happens is that it can cause apoptosis or cell death of those cells. It starts in the periphery and then goes centrally. So patients can have what's called keratopathy, which is what the eye doctor will tell us is that there's changes on the cornea. Patients don't have blurry vision or changes in vision until those changes in the epithelial layer occur centrally, okay? So we see that the majority of patients get keratopathy. They get these changes that the ophthalmologist can see, so 72%. So 56% have blurry vision, dry eye, symptoms, okay? 18% have a change in their ability to see clearly, okay? And 3% had to discontinue because of the ocular events. So while Blenrep has gotten a bad name for the ocular toxicities, it doesn't, the patient's eyes are not affected or their quality of life is not necessarily affected all the way across the board when patients are on this. So I have a lot of patients on Blenrep because we were part of the DREAM2 trial and I'm very comfortable with this drug. And a lot of times patients will tell me about some blurry vision, maybe some dry eyes, maybe itchy eyes. We give them eye drops, we give them a dose hold, and generally that goes away. We're even able to restart the drug, sometimes at a lower dose, and find a dose that's more tolerable. But I have many patients who have been on this drug for well over 18 months, and they continue to have really impressive responses. And these are patients that weren't responding to other drugs. So it can be a very good drug, but the ocular toxicities are something that needs to be appreciated, but not necessarily something that our patients need to be scared of. So this is some practical considerations. We just put out a paper on therapeutic advances of hematology, and this is one of the tables from that paper. Patients are required to have eye exams before treatment and then within 2 weeks of getting their next dose, just to make sure that we're keeping a close eye on those eyes. Patients are required to have eye drops and use those 4 times a day. I think importantly, the GSK has done a nice job at providing free eye drops for the patients. They have an eye drops program. Patients shouldn't be wearing contact lenses. We have to communicate. We want our patients to tell us exactly what they're experiencing so that we can help make their eyes better. And then patients need to be advised that they shouldn't be driving if they're experiencing blurry vision. It's sort of like having to remind the 88-year-old guy that he shouldn't be driving his car. But let's move on. So CAR Ts, everybody's excited about CAR Ts, as we should be. All right, next generation goodness. Okay, this is Craig Cole again. So if you don't like this one, you can email him. If you do like it, you should cheer again. Maybe I'll take a picture of that. So this is CAR T cell therapy 101, we hope. So T cells are a type of white blood cell that attack and kill viruses and cancer cells. Chimeric antigen receptors, or CARs, help T cells recognize and destroy the cancer cells. The idea here is to program the patient's T cells with the CAR to recognize and destroy the patient's own CAR or their own cancer cells. All right, so what do? Many of you guys have been around autologous transplants. We collect stem cells. In this case, we want to collect T cells. So we collect T cells from the patient. The machine removes the desired cells from the blood, then returns the rest of the blood back to the patient. Very similar to stem cell collection. Those are the T cells. That's a virus with the chimeric antigen receptor gene in it. So this modified virus, in blue, is used to transfer DNA to the patient's T cells so they will produce CAR proteins. Oh, it gets more impressive. All right. The CARs have two ends. They have a binding site specific to the tumor cells and a signaling engine that activates the T cell to kill the tumor it binds to. So the way I explain this to patients when we're in the clinic and I don't have this fancy stuff is we have the T cell and that antibody is basically sticking in the outside of the T cell. And just like that antibody drug conjugate, that T cell can go find the myeloma cell and attach to it. The patient's T cell is now expressing a cancer-hunting CAR receptor. So then once we've designed this construct, then we expand it, okay? We don't want one, we want many millions. We want hundreds of millions of this thing. And then we want to infuse it back into the patient. Okay, it's very important to understand that this is not an overnight process yet, okay? So what happens is we have to plan. CAR T slots are limited. Maybe not at Roswell and MSK, but in Utah, it's limited. We get allocated spots, okay? So we have to plan. We've got these lists of hundreds of patients that need CAR T cells. And so we take these spots and we figure out who needs the drug the most. Who can we actually get to that therapy? That's going to be, we got the spots 2, 3, 4 weeks out. So a patient has to wait a month for that. They undergo collection, and then it takes another 4, 6, sometimes 8 weeks to get this back, okay? So these things have to be engineered. So this is not an overnight thing. This is maybe 2 months, 3 months. So we're talking about utilizing CAR T cells in patients who have seen a lot of treatment. Go back to that figure that I showed earlier. You get into 5th, 6th relapse. We don't have a lot of time, okay? And so right now, CAR T cells are an incredible resource for us, but we're not at the point where all of our patients can get them. But that's what we're getting to, okay? And we'll talk more about that this afternoon. So right now, it's late line. It's going to be moving towards first line soon enough. Okay, so what did you guys think? Yes, no? Yeah, okay. If he was here, I would say something like, Craig Cole, ladies and gentlemen. All right, so CAR T and myeloma backgrounds. So we have the BCMA. Again, BCMA is like the popular kid at school. We've made all of these different drugs directed against BCMA, but we have other targets that are coming. Basically just went through this. This is another picture. This is what's happening once we infuse those T cells. So we've got those CAR T cells. They're going, they're attaching the BCMA on the myeloma cell. They're expanding, and what's happening is we get the POW. Okay? And just for the record, I like POW in one of two ways. This way, in which cancer cells are being killed, and up there, when we get a lot of snow. All right, so this is a pictorial of what a BECMA looks like. A BECMA has a single binding domain to BCMA. It has been FDA approved based on the KarMMa 1-2 trials. This was approved in 2021 for patients with at least 4 prior lines of therapy, including immunomodulatory drugs, PI, and anti-CD38 monoclonal antibodies. This is some of the data. You can see, I don't have my pointer, but the third bar over is the overall response in all comers. Overall response in those patients that got targeted, the targeted dose was 81%, and the overall response in all comers was 73%. As far as progression-free survival, so how well is it working? In those patients that get into a complete response or better, you're talking about a median progression-free survival of about 20 months. In all comers, 8.8 months. We're trying to figure out why that's not longer, okay? Some patients do really, really well. Some patients not as well, okay? You're gonna see a bunch of data coming out at ASH this fall, I guess in December, trying to tease out what it is. What are the factors that are associated with a lack of durable response? So this is Carvykti, a drug we know very well, also known as Cilta-cel. Thankfully, we are able to provide this for patients here in this region. I feel honored to be able to say that because it was a lot of work to get there. But this is, we get 1 slot a month, which is a huge win. Because I would say that if this was coming 5 years ago, we would never have the capacity to be able to do this. So this drug is likely better. We think it's better. We think we know it's better. It has 2 binding domains to BCMA, okay? So it binds tighter, binds better. So based on the CARTITUDE-1 trial, it was FDA approved in April for patients with at least 4 prior lines of therapy, again, including immunomodulatory drugs, proteasome inhibitors, and anti-CD38 monoclonal antibodies. This is some of the data, okay? What should you focus on? CARTITUDE-1, CARTITUDE-2, the first 2 lines there, heavily pretreated patients in CARTITUDE-1. The follow-up is about 27, 28 months. Overall response, 98%. Just need to think about that for a second. These are patients that in that figure that I showed you that Dr. Sherbino gave me, 5th, 6th relapse, and you're talking about basically not being able to get responses. And now you're talking about 100%, almost 100% of patients getting an overall response. And they were deep responses. So, and those responses deepened over time. So the rate of stringent complete response or better at 24 months, 83%. 55% of the patients were MRD negative. Median duration of response has not been reached at 28 months, nor has a progression-free survival. Yeah, I think it's worthwhile to just let that sink in. It's a game-changing drug, just like Game Changers and plant-based diet, right? It's next level. So how do I go back? So the Legend 2, the drug that we have here in the States is similar to a drug that was developed in China, and that drug has been on the Legend platform. So Legend 2 there has a little bit longer follow-up, 4-year follow-up. Drug, it wasn't showing as impressive responses, so as we're seeing with Carvykti, the median progression-free survival is 18 months. in all patients. But I will say that it's still a very good drug and only getting better. But it's not without toxicities. One of the reasons that I barely walked in and I missed my colleagues' talks this morning was that we're dealing with a lot of neurotoxicity and cytokine release syndrome on the inpatient service right now. Okay, and it's not so much with the myeloma drugs, more with the lymphoma drugs, but it's important to really point this out. So ide-cel, our experience with ide-cel. So cytokine release syndrome, what is cytokine release syndrome? Basically, it's a massive inflammatory response. Manifests in all sorts of ways, namely with fever, need for oxygen, sometimes need for blood pressure support. Things generally don't get much worse than that, okay? In general, patients who are treated with Abecma experience CRS within about 1 to 2 days. So what does that mean? So what we do is we infuse the drug, and then we admit patients that day. Like my guy who got Abecma 3 days ago. Was admitted, had fevers to 40, gave him some Tylenol, cooled off, had another fever, cooled that off as well, and now he's in cruise control, okay? So that was cytokine release syndrome, and very typical what we see in our Abecma patients. But we can also see neurotoxicity, or ICANS. So what's that? That's inflammation in your central nervous system. Pretty low grade, not real common, but it can happen. What do patients experience? They experience headaches, confusion. We make them do this assessment. It's called the ICE assessment, where they have to write down, they have to write a sentence, and they have to try to remember what date it is and where they are, and those things that we take for granted. Patients can't do that. And when things get very severe, patients aren't thinking, they're not reacting, okay? So it can be very dangerous, but with ide-cel, it is generally not that way. Common toxicities we see, cytopenias, diarrhea, fatigue, decreased appetite, headache. A lot of those toxicities are what we see from the chemotherapy that we have to give before the CAR T-cell. Okay, so cilta-cel is a little bit different story. We see the onset of cytokine release syndrome a little bit later, about the 1 week mark. And we see a little bit more neurotoxicity with this drug, so we need to be very careful. We think that those patients with higher tumor burden have higher risk of neurotoxicity, so we're trying to figure out what the optimal bridging therapies are as we're taking those patients from collecting their T cells to actually infusing these. I'm talking way too much, so I'm going to run out of time. You guys okay if I go over a few minutes? Is that, yeah, okay. So next up is the bispecifics. We have a lot of them. There's a bunch of different platforms. I wish that I was so good at coming up with these names that they'd pay me for it, but you had a good one. It was the microbiome with the double M. I like that. That's good. So these are Majestic, looking at TEC or teclistamab. Magnetism is looking at elranatamab. We have Paradigm looking at Amgen 701. Monumental, I think Janssen's winning the race here. But that's looking at telquetamab, that's directed against GPRC5D, and we have cevostamab, which is the Genentech Roche, which is directed against FcRH5. So all these drugs are moving forward. Most of them or the ones that are furthest along are those directed against BCMA. So again, Craig Cole, he's our guy. I'm going to explain this in a minute. Okay, so what this drug did, if you imagine I'm the drug, right? I'm grabbing a T cell, I'm grabbing a myeloma cell, and I'm bringing them together, okay? And then what happens? Seriously, right? It's so good. And then we get the POW. So the Majestic is a game-changing platform. So teclistamab is an off-the-shelf T-cell redirecting bispecific antibody. You can't call it a BiTE. A BiTE is the Amgen product, so we call them redirecting bispecific antibodies. This binds CD3 on the T-cell and then binds BCMA on the plasma cells. The Majestic 1 is a phase 1/2 trial. Patients who had were heavily pretreated, at least 3 prior lines of therapy, including PI, IMiD, anti-CD38 monoclonal antibody. We are expecting this to be FDA approved in about 4 weeks. If that's the case, it should be in clinic very, very soon. This is, again, a game changer. We'll go through this, and I got a couple of statements at the end, but the bispecific is going to be used in a lot of different settings. It'll be interesting to see what happens, how we start sequencing these drugs. But when you look at its performance in patients who are heavily pretreated, you're talking about 63% overall response rate. Okay. Well, what's nice about the bispecifics versus the CAR Ts? Okay, well, maybe that's not 100% overall response rate, but I don't have to have patients wait 3 months to get it. Okay. I can get them either on clinical trial or when teclistamab comes standard of care, it's off the shelf. We can just give it. Okay. So patients who can't wait for CAR T cells, the bispecifics are going to be a really good option for them. And then median duration of response is 18.4 months on the TEC-1/2 trial. TRIM2 is the first trial looking at the combination of the bispecifics plus daratumumab. You know, there's this thing that happens in myeloma is we find a good drug, and then we add it with other myeloma drugs, and it gets better, right? So when you're a clinical trialist, that's sort of how your brain thinks. So TRIM2 is a phase 1b, looked at TEC plus DARA, and then had another arm looking at talquetamab, the GPRC5D, bispecific and daratumumab. All the rest of that is not important other than to say that there's a bunch of different doses we're looking at because we're trying to optimize this so it can be given as an outpatient, not just inpatient as it is now, and then patients were heavily pretreated. And you can see that when we combine the drugs, the response rates go up, okay? And the data is still very young. But when you're talking about, you know, comparing these bispecifics with, say, daratumumab, single-agent daratumumab had an overall response rate of just over 30% when we were looking at that. And that was looked at in patients who were refractory to immunomodulatory drugs and proteasome inhibitors. Now you're talking about a drug that's got an overall response rate of 60% in patients who are refractory to those monoclonal antibodies, the IMiDs and the PIs. So we think that these drugs are much better. So these are some of the other drugs that we see, some of the other bispecifics. We'll talk more about this afternoon, but you can see across the board the overall response rates are pretty similar. It'll be very interesting to see what drugs actually make it to market and in what setting they make it, because the fight is on, basically. Teclistamab will be the first, and then it'll be interesting to see who's next, and who figures out how to use this drug in the outpatient setting first. So lastly, I'll just gloss over selinexor. Selinexor is a selective inhibitor of nuclear export. Basically, if you're a cancer cell, you want to kick out these proteins that are in your nucleus called tumor suppressor proteins because you want to stay alive. And so what this drug does is it shuts that transport down, and those tumor suppressor proteins stay in the nucleus and are able to kill the cell. Selinexor, you're not going to go through all this, and selinexor can be toxic. We're now working on figuring out how to make it more tolerable because it can be a very effective drug. As you can see here, it can be more effective in combination. Okay, ideal dose, in my mind, ideal starting dose is 60 milligrams once a week. It's nice, it's oral, but it needs to be combined with other drugs to be very effective. You can see on the last line there, and I think that this is one of the reasons that I included this table, is that in the post-CAR T setting, selinexor has been effective. And I can tell you a patient case just to highlight that. So this is a woman who has 14 prior lines of therapy, goes up to Fred Hutch, gets a GSI plus CAR T, BCMA CAR T. She gets about 1.5 years out of it, comes back to me. She's basically blown through everything. So I picked some selinexor, threw a little bit of carfilzomib on board, and then she had MRD negative within 6 weeks. So it's really pretty cool. Once we give these CAR T cells, it seems to change the entire immune microenvironment, and I think that we will be learning over time just how to best optimize our drugs in that space. So not that you guys need to know all these things, but this is just to say that when we use selinexor, we have to use a lot of supportive care, especially in the first cycle or two. And then once we get somebody rolling on it, usually 2 months in, if they're tolerating at that point, then they'll do just fine. Okay, so I was asked to put a couple of thoughts together about sequencing. I think that sequencing is really unknown. I think that, the three of us, when we're thinking about this every day, we're sitting in clinic going, I don't know. I got these good drugs. I'm going to use my best drugs first, right? And you say, okay, well, you're refractory to that drug, so I'm going to use this drug and combine it with another drug because that's got the best data. Okay, and then every time we think that we have an algorithm worked out, you get a new drug, which is great. It's a great problem to have, but it's something that we struggle with. So these are a couple of my thoughts. So establishing with an academic center early is essential to have access to these drugs. Clinical trials are the way to go at this point, in my opinion. Okay, these drugs are very, very good, and moving the field forward quickly at this point is very important. And so we want all of our patients on clinical trial if they are able. If possible, we always use the best drugs first. Right now, in my opinion, these are the BCMA-directed CAR-Ts and bispecific antibodies. In patients with translocation of 11-14 disease, which I didn't talk about, if they're venetoclax naive, I strongly consider a BCL2 inhibitor, standard of care, or on clinical trial. This is venetoclax, and there's a couple of other agents out there being studied. If possible, avoid BCMA-directed therapies before Abecma. Okay, we had a real-world analysis as part of the CAR-T consortium that showed that those patients that were exposed to either bispecifics or mostly the BCMA ADC, antibody-drug conjugate, did not do as well. Okay, didn't have as deep responses or as long responses, but this is still very early and we're just trying to pick up signals. The BCMA-directed bispecifics and ADCs may be an option after progression on BCMA CAR-T. Many of the bispecific trials are allowing prior BCMA therapy. So we have a lot of patients who are progressing off of BCMA CAR-T cells going on BCMA-directed bispecific trials, and the responses so far have been really impressive. There are many more highly efficacious and safe drugs coming soon, and we're now moving towards sequencing drugs with similar mechanisms of action that have alternative targets. So the idea here is you got a bunch of bispecifics, maybe use one BCMA bispecific, and then you move on to a GPRC5D bispecific. What's that going to look like? So that data will be emerging as well. This is probably the most important thing I can tell you today. Don't yell at your myeloma specialist if all these drugs are not available right now. We're all trying super hard. And then if necessary, utilize Blenrep, Selinexor, or something like bendamustine or Cytoxan in combination regimens if you need to get to the next therapy. So in summary, the world of myeloma-directed therapeutics is rapidly changing. The CAR-T and bispecifics represent a generational shift in the treatment of our patients. Alternative targets are being actively investigated in clinical trials. We're improving by leaps and bounds, absolutely no question. Drug sequencing algorithms are virtually impossible because things change so frequently. And lastly, I will say this is the most important thing. Be hopeful. We've come a long way from melphalan and prednisone in a relatively short period of time. And with that, this was me about a month ago in the Arctic skiing. She was making fun of me because the week before I went, I was working on my irrigation and I sliced my extender tendon right in half. And so my thumb wasn't working real well, but I still got after it. So anyway, thank you.
Yeah, I think you still got after it, that's for sure. And I think leaps and bounds is an understatement. That was so insightful. I think sequencing is the million-dollar question, isn't it? And thank you, Dr. Sborov, for your insight on that.